All right, welcome to the President's Symposium, Health Literacy as a Social Determinant of Health, with the University System of Maryland Chancellor Jay Perman. I'm Alex Lukowski, Executive Director of Media Relations. I know we're all very excited to have Dr. Perman back at UMB, if only virtually, to moderate our panel this afternoon. The focus of this year's President's Symposium and White Paper Project, Health Literacy as a Social Determinant of Health, is a subject that I know is very important to him. Joining Dr. Perman are three nationally recognized experts on the topic of health literacy. You'll hear more about them in just a moment. And you'll also have a chance to converse directly with them in a small breakout session later in the program. I want to remind everyone that this program is being recorded and will be posted on the UMB homepage, umaryland.edu. If you have any questions or comments, please write them in the chat area. When the time comes, we'll call on you by name, so just be ready for that and we'll turn your mic on for you. Now it's time to introduce the president behind the President's Symposium, UMB President, Dr. Bruce Jarrell.
Thank you, Alex, and good afternoon. I thank you all for joining us. This is the President's Symposium on Health Literacy as a Social Determinant of Health. The President's Symposium and White Paper Project is an interprofessional initiative.
Recording stopped.
Begun over a decade.
Recording in progress.
Begun over a decade ago. Its purpose was to engage faculty, staff, and students, in this case, in a year-long conversation on a topic that was of interest and very much importance to the university and its community. This year, the fellows are focused on health literacy. A patient who is well-informed, i.e. is health literate, can become an active decision maker for his or her own health, as well as the health of his or her family. And so the key question that the fellows are asking is, what is the university's role in teaching our students, as well as we, the faculty and staff at the university, about this topic, therefore improving the relationship between the provider and the patient, which is certainly an important part of our mission. To hear more about this, I'd like to introduce Professor Cynthia Bauer. Dr. Bauer is an endowed professor at the University of Maryland College Park and director of the Horowitz Center for Health Literacy. Dr. Bauer, welcome, and I'm looking forward to your comments.
Thank you so much, Dr. Jarrell. Very happy to be here with you today. So I was asked to just give a few opening remarks and then introduce our chancellor, who will be moderating today's panel discussion, and to provide a little background about this activity and how we got to the symposium today. This project is co-managed with me by Dr. Elsie Steins, who's in the Office of the President at the University of Maryland, Baltimore. And she and I have had the privilege of being part of a faculty and student team since last June. We began a 10-week session under the umbrella of Empower, which is the state's initiative to have the Baltimore and College Park campuses collaborate on meaningful activities. And I know Dr. Perman was very instrumental in helping initiate those Empower activities. And then under Dr. Jarrell's wise counsel, we extended that activity into the year as part of the President's White Paper and Symposium activities. And so we have a great cast of 9 fellows who've been working through the summer and through the academic year that will culminate in that presentation of recommendations on April 6th. So that's just a very quick overview. I want to give a shout out to about a dozen faculty from both our campuses that have been really integral to this process, as well as those 9 students who've been working very hard and who are present today in the symposium. So without further ado, I'm very happy to introduce Chancellor Perman. He told me not to give a big fancy and flowery introduction, but of course he is the chancellor of our system. He is the former president of the University of Maryland, Baltimore, very key to the initiatives, as I indicated, like Empower, the President's Symposium, the President's Clinic, which is an interprofessional clinic of which I know he and Dr. Steins are quite proud. And I think, I haven't known Dr. Perman all that long, but in my observation, I think he's also quite proud of being a patient-centered practitioner and really empathetic and takes the concerns of his patients and families very seriously. So I believe this topic that we're talking about today is near and dear to his heart. So thank you so much for your leadership, both to Chancellor Perman and President Jarrell on this activity and these initiatives, and I look forward to today's conversation.
Thank you, Dr. Bauer. Thank you, President Jarrell. Colleagues, all of you, I'm so pleased to be in front of you for multiple reasons. You all know that UMB was my full-time professional home for so many wonderful years. And I am very happy that it remains my part-time faculty home, where I can be a faculty member, a clinician educator. I'll come back to the clinician educator part in a moment, but it really is nice to be home. Secondly, as Dr. Bauer indicated, you all know that I am particularly delighted to see Empower in action. This is Empower in action. The partnership of College Park and Baltimore, as demonstrated this past summer by wonderful students from both institutions, and now throughout the year by wonderful faculty from both institutions. Make no mistake about it, Dr. Bauer has been very kind, but I, together with you, am going to learn something from this afternoon. I'm going to learn something that I talk about, but I am not a scholar in. And you're going to hear from scholars in health literacy and social determinants of health and interprofessional education. And the reason I'm excited about it, I'm going to learn something about it, is because each Tuesday afternoon, as Cynthia mentioned, here at UMB, I talk about these things because I get the privilege of working with students from each of UMB's professional schools as we see patients together. We've called it President's Clinic for all these years. Dr. Jarrell has given me license to continue to call it that. I mean, who would know what the Chancellor's Clinic is? But I usually find myself saying the following to the students, and here's the point. What I say to the students is something like this. If you think that by making the correct diagnosis and prescribing the correct therapy, you're done, you have served the patient, you're not done. You're not done. And if you think you are, for so many of our patients and families, you're fooling yourself. And it's very important not to fool oneself. Now, why do I say that? You all know why I say that. Because for too many of our families and patients, they come with a broader context, with a broader environment. Maybe they have too little money, perhaps no transportation, little access to good nutrition, challenges in managing the treatment plan, including the medications that multiple providers prescribe and how they interact. They may have limited understanding of a healthy lifestyle and poor understanding of what we assume they know or what we assume they understand in what we told them. And that's on us. That's our fault if they don't understand. That's for us to fix as far as I'm concerned. So all of us, not just health profession students, not just health practitioners, but all of us, and this audience is filled with leaders. You're all leaders. or potential leaders, we all need to listen to these experts on health literacy, these experts that speak with us today. And so it is an honor to be joined by three of the country's foremost scholars in health literacy and social determinants of health in interprofessional education. And I might say three leaders whose scholarship is also informed by years of patient-centered care that they provide. I'm going to introduce our three panelists at once, and then they're each going to make remarks to you. Dr. Dean Schillinger will speak to us first. He's professor of medicine at UCSF. It was my first academic home, so it's nice to have you here, Dean. He's a public health and primary care physician, an internationally known health communication scientist, and an expert in chronic disease prevention and control. He directs the UCSF Health Communications Research Program. He co-founded the UCSF Center for Vulnerable Populations. He's principal investigator for CDC and NIH-funded projects in diabetes-related policy, and he's PI on an NIH project to develop measures of health literacy using computational linguistics and machine learning. Thank you for joining us, Dr. Schillinger. Dr. Denise Rogers is Vice Chancellor for Interprofessional Programs at Rutgers Biomedical and Health Sciences and RBHS Chair in Interprofessional Education at the Rutgers Robert Wood Johnson Medical School, where she's Professor of Family Medicine and Community Health. Previously, Dr. Rogers served as the 5th president of the University of Medicine and Dentistry of New Jersey. She has spent much of her career caring for poor, minority, and disadvantaged patients and communities. This is not Dr. Rogers' first time on our campus. She led the Middle State site visit for our reaccreditation. And I was honored to get to know her then, as many of you got to know her. Delighted to have you back, Dr. Rogers. And finally, and last but not least, Dr. Steven Chen, who is Associate Dean for Clinical Affairs and the William A. and Josephine A. Hears Chair in Community Pharmacy at USC. He's principal or co-investigator on several grants evaluating the impact of comprehensive medication management on healthcare quality, safety, cost, and patient and physician satisfaction. While at USC, he's founder of the California Right Meds Collaborative, a partnership of California health plans, community pharmacies, and pharmacy schools, providing comprehensive medication management services. Steve, delighted to have you here. Thank you for joining us. And with those introductions, I will call on Dr. Schillinger.
Thank you, Dr. Perman. Before I begin, I just wanted to make a few introductory remarks. First, I wanted to congratulate the University of Maryland for tackling this topic and entitling it in such a provocative way. I think it's a very interesting way to engage the academic community there and to consider how to move forward as an institution with respect to mitigating the health problems related to limited health literacy. I also want to point out, in addition to thanking Dr. Bauer, that you all have a diamond there in the Horowitz Health Literacy Center. It's a very unique asset that you have at the university, and I think it bodes very well with respect to the ability to follow through on recommendations, that you have that kind of expertise and degree of resources on campus. I guess, on that campus, and maybe collaborating with the other campus to bring public health and medicine together around the issue of health literacy. We were talking before the call, I just came from clinic, and I was thinking as you were making your remarks, Dr. Perman, on sort of how this manifested itself in my clinic just a few hours ago. And one of my patients is a lovely woman, a Chinese immigrant, speaks Chinese only, always comes with her husband. They're a lovely family. She has a number of chronic medical conditions. I first met her when she had what we call thyroid storm. She had a thyroid hormone problem, and I've been her primary care doctor now for over 25 years, and she has developed a number of chronic conditions, including high blood pressure and diabetes. She comes from a low-income background, lives in a low-income neighborhood. And, we were looking at her medication bottles, and she's on around 9 different medications. And in the last few visits, I've had to not only escalate her blood pressure regimen, but I've had to add additional medications to manage her blood pressure. And so I don't know what came over me, but I asked her, I wanted to assess her understanding of why she's on all of these medications. And rather than ask her, do you know what high blood pressure is? Because nobody actually knows what that is. I asked her, do you know what the problems that could occur to you if your high blood pressure were not well controlled? I just want to make sure you understand why I keep increasing these medications and why you have so many medication bottles. And for those of you who don't know, the reasons we treat hypertension are to prevent kidney failure, to prevent heart disease, and to prevent stroke. So she looked at me, and through the interpreter, she said, no, I actually have no idea. And I've been treating her for probably 20 years. And she's been religiously taking those medications, I believe. And I said, well, it's, we do it for 3 reasons. One is to prevent heart attacks and heart failure. The second is to prevent kidney failure. And the third is to prevent strokes. And she said, oh, good. Okay, thank you. And then I took it one step further based on some prior research we've done. I said, do you know what a stroke is? And, people, particularly Chinese immigrants who have hypertension, have very high rates of stroke. And these can be quite disabling, if not fatal. And she said, no, she doesn't know what a stroke is. And I asked the translator to, again, make sure that she's communicating it effectively, and she used the right word. And she said, I'm using the right word. So she, like most people, do not know what a stroke is. And so I explained to her what a stroke is in terms of the death of part of the brain, and it could leave you paralyzed. And as soon as she had the mental image of someone in a wheelchair paralyzed, then she understood the importance of taking her blood pressure medication. Now, she was not having problems with adherence, but this was really an ethical question in my mind as to why she needs to understand why she's taking these medications. Now, it's also important to recognize that so that's a health literacy issue in terms of her individual health literacy, but it's also important to understand why she has high blood pressure to begin with. We consider high blood pressure to be a quote unquote diet-sensitive chronic condition. So she lives in a neighborhood where there is minimal access to healthy foods, fruits and vegetables in particular. She has a very high sodium diet, and she is surrounded by retail food outlets that provide almost solely high sodium diets. Now, you and I may know to look at the label and understand the milligrams of sodium in a particular product. We may have the resources to purchase fresh fruits and vegetables. And we also know that there have been randomized controlled trials in low-income communities that if you actually provide what's called the DASH diet, or fresh fruits and vegetable rich diet, that people's blood pressure drops precipitously. So the health literacy that she needs to have, and we need to have as a public health community around changing the environment in which she is living her life, is probably as important as her understanding of the medications that she needs to take. So I want to bring these two things together in a moment. The final thing I want to say is this is a very sophisticated crowd, I understand. So I will say that, putting it out there that whether health literacy should be considered a social determinant of health, or whether it's a mediator of health outcomes with respect to the relationship between established social determinants of health, like education, race, income, et cetera, or whether it's what we call an effect modifier or a moderator, where it's an important mechanism for both those who are subject to the social determinants of health and those who benefit from current societal structures. It's probably not that important. It's an academic point. I think the issue is as to whether or not we call it a social determinant of health is probably more of a political one than a scientific one. What we do know from the existing research is that at least in a number of studies, individual level health literacy has been shown to mediate, to be an explanatory mechanism for observed differences in health outcomes, particularly health care outcomes, in chronic disease with respect to both educational attainment and, in some studies, race ethnicity. This does not mean it explains the disparities observed entirely. In almost all of these studies, they were shown to be partially mediating or explaining the differences. Less is known, much less is known about whether it has a mediating or moderating effect on limited English proficiency, on immigrant status, and other social vulnerabilities. Now, before we go on and think through the implications of those somewhat limited research findings to date, I want to share a conceptual framework that I think is very important to consider as we move forward. I'm wondering if the slide that I sent could be put up. So, well, you're going to have to trust me on what's behind the gray. This is a unifying conceptual framework for the pathways that can connect social determinants of health, such as educational attainment, race, ethnicity, income, immigration status, etc., that connect those social determinants of health to health literacy and to health disparities or health outcomes, which is what's hidden behind the gray. And the key point I wanted to make is that there are two predominant pathways that we need to discuss. The pathway on the left is where Dr. Bauer sits at the School of Public Health. It's the public health pathways. It's the ways in which the social conditions and the environment that our populations live in or are grow up in that determine health outcomes. And there is a population level or public health literacy that can influence the degree to which that pathway leads to poor health. And on the right is the healthcare pathway, again, related to resources and assets that come with healthcare and the attributes of healthcare organizations themselves that can be influenced by a patient or family's level of health literacy and have consequences with respect to health outcomes. Now, let's focus on the pathway on the left for a moment. What this pathway suggests is that social determinants of health operate to determine health outcomes through a balance between the life course exposures that individuals, families, and communities have based on where they live and how that society is structured around them, as well as the resources that they have as communities to buffer against those exposures or even prevent exposure entirely. So coming back to my patient with hypertension on 6 different medications and diabetes, her chronic diseases are almost entirely a consequence of the structures in which she is living, the structural resources. Think about structural racism, that's what that is referring to, and the exposures that she is subject to as a result of those resources. Now, she also has structural assets. She has a very strong cultural heritage, very strong family life, and a tight-knit community that can lead to resilience and mitigate those life course exposures. Our communal public health literacy will impact the degree to which her life course exposures will or will not affect her health. Her ability to advocate on behalf of her own community to make sure that there are more grocery stores that serve DASH-like diets is a function of her health literacy and our communal public health literacy. Now, on the right, health literate healthcare organizations are the structures that need to be in place in order to ensure that healthcare access and quality are of the kind that will reach patients like her, someone who does not have exceedingly high health literacy. As Dr. Perman was saying, is what can we do as organizations to make her navigating the healthcare system, given the fact that she has additional added burdens because of the environment in which she is living, to make it easier for her to prevent and control her diabetes and hypertension, and to prevent her from having an untoward outcome like a stroke. The next slide. This is my last slide. I want to really raise an important caveat. If we could move to the next slide. So there are caveats regarding the existing research that is out there that has asked the questions of, is health literacy a social determinant of health? And does health literacy mediate the relationship between social determinants of health, specifically race, ethnicity, and health outcomes? Now, I'm someone who has spent much of my career trying to demonstrate the importance of health literacy and health communication to mitigate health disparities. But I want to be very clear that the research that has been undertaken to date is extremely problematic. And we need to be very aware of how those problems may arise as we think about orienting our focus to health literacy as either a social determinant of health or as an explanatory factor for health disparities. And thinking about these problems will help us make more informed decisions around policy and practice solutions. The first problem is we have a problem with measurement. When we measure an individual and we say, you have low health literacy, we need to understand that these measures are subject, like any measure, to a degree of mismeasurement. But in particular, what we've learned from critical literacy studies in the field outside of medicine is to think about the question, well, who gets to decide? Who gets to decide what is high literacy and what is low literacy? Well, it is the dominant culture that gets to decide. It is white academia primarily who gets to say, this is what the literacy test is testing you on. This is what knowledge is. We have decided how to pronounce certain names. And if you mispronounce a name on our literacy test, if you mispronounce a medical term, we're going to count you as having 0 points on that, and you will have a low health literacy score. So you can imagine how individuals who've been marginalized and oppressed and populations who've been marginalized and oppressed may not have the same linguistic toolbox. I'm not saying it's a lesser toolbox. It may just be a different toolbox in how words are used and what words mean and which words are important. But if the dominant society that has been oppressing these individuals gets to decide what is or is not literacy, there may be an inherent problem that leads to bias in measurement. Now, relatedly, and let me just make one other point. Assessing individuals' capacity to manage their health by assessing their literacy has significant historical problems. Minority populations in the history of America, literacy has been withheld from them in prior generations. Literacy instruction was withheld from them, and then literacy assessments were used to determine whether they could actually be active civil participants to vote. So there was, until very recently, and it may happen again, literacy tests in the very recent past that one had to pass in southern states in order to be allowed to vote. So sure, you could vote if you're white and black, but you had to pass a literacy test. And guess what? Guess who gets to make the literacy exam? And you should Google what some of these literacy exams were like. And you should know that they were differentially given to African-American voters. They were not given to white voters. So the measurement of literacy is very problematic, and we need to be very concerned about the implications that this has for how we move forward. I'm not saying this is not a problem. I'm saying we need to move cautiously. Lastly, there are issues related to misattribution. By that I mean, we've measured you have low health literacy. We see that it's related to your health outcome. Therefore, we will attribute your poor health to the low literacy, not attending to the fact that we may not have considered either residual or unmeasured confounders like income or education. You may say, oh, well, we adjusted for income. But we know adjusting for income at one point in time does not measure a lifetime exposure to poverty, nor does it measure wealth, the accrual of income and assets over time. So confounding is a significant problem. In addition, there is cyclical and reverse causation. We have shown that if you have long-standing diabetes that's poorly controlled, it affects your cognition and can affect your literacy test. So it's the poor disease control over time that then leads you to have a bad outcome on your literacy exam. So which came first, and what are we attributing the relationship between health literacy and poor diabetes outcomes to? We may be misattributing it to an indicator of longstanding exposure to poverty or racism. The third is attention bias. And attention bias refers to the things we as scientists decide to focus on, to pay our attention to. And even though we may find a p-value less than 0.05, is that really where the public health or clinical action is? So again, I'm just calling out some caveats. I'm not saying throw the baby out with the bathwater. And the last is attribution bias, which is when we find that the relationship exists, and in fact, in our statistical model, it is statistically significant as a mediator. That does not mean that we must attribute the relationship to a causal one. So it may be that health literacy and literacy in general is simply a very robust indicator for lifelong and historical oppression. It is the thing we can measure that captures oppression, but it's not the literacy that's the problem, it's the oppression. I'll leave you with those hopefully provocative comments and hand it off to my old colleague from San Francisco General, Denise Rogers.
Thank you so much, Dr. Schillinger. It is always mostly a pleasure to follow you because you're so provocative and compelling in your remarks. So I'm going to start sharing my screen now, and hopefully you will be able to see my slides. So one of the things that I want to talk about is the fact that the COVID pandemic obviously has brought the reality of the problem of low health literacy into even greater focus. And I want to emphasize that certainly the literature suggests to us that as measured currently, low health literacy certainly is seen disproportionately in communities of color and disproportionately in populations that actually have low overall literacy rates. But the interesting thing about COVID is it's shown us that low health literacy actually exists at every level in this country. When we have people in very, very high places in this country suggesting things like drinking bleach or like putting ultraviolet rays into the body in order to treat disease, that would suggest to us that there are levels of a lack of health literacy that transcends the groups that we traditionally think of as having low health literacy. What we also know, though, from COVID is that low health literacy, or basically a lack of understanding about sort of how the body works, really contributes then to people's misunderstandings about how to treat disease, how different therapeutics work. We certainly hear about concern about, an mRNA vaccine interfering in someone's genetics. And so this current pandemic has really called out for us many of the challenges that we have around health literacy in this country. I want to say, though, that we've been talking about health literacy for a fairly long time. And in 2004, the Institute of Medicine issued this report, Health Literacy, a Prescription to End Confusion. At the time of the report, it was estimated that there were 90 million adults who were health illiterate. By 2013, the Center for Healthcare Strategies was suggesting the number may look more like 115 million. What is pretty clear that David Kendig alluded to, he was the chair of the group that put together the IOM report, was that efforts to improve quality, to reduce costs, and reduce disparities can't succeed without simultaneous improvements in health literacy. In other words, unless we have people obtain a better understanding of their own health issues, it will be impossible to really overcome many of the challenges related to disparity. Now, let's be very clear. Improving health literacy alone is not going to come close to getting us where we need to be to eliminate disparities, but it is probably a very important component. The other thing that Kendig says is that improving health literacy requires great effort from public health and healthcare systems, the education system, and society overall. And I think one could argue these many years later that we certainly haven't seen that great effort come to pass by and large. In 2012, the Institute for Healthcare Improvement introduced the Ask Me 3, which really was somewhat exemplified actually by what Dr. Schillinger started with in terms of talking about his patient. So having his patient understand what is her problem? What is it that she needs to do? And then why is it important for her to do this? So I have hypertension, I need to take my medications, reduce salt in my diet, and it's important for me to do this in order to prevent kidney disease and heart disease and having a stroke. So this is great. And I think when IHI released this, their intention was that this would just be utilized widely and everybody would adopt this and you can download the materials for free from their website. And this was going to be a major source of the solution. Well, there's only one problem. Certainly it's not particularly user-friendly if you can't read, and it's not particularly user-friendly if you can read, but you only read at a third or fourth grade level. And it really isn't user-friendly if you can't write, because the expectation is that you have to read all this stuff and then be able to write out your answers, and then be able to write out your answers in a way that you can take them home and then reread them and the like. So I'm not saying this is not a useful tool. I am saying it is a tool that has limited utility, if you will. But what all of this, even from 2004, has really raised for me is whose problem is health literacy? I mean, we certainly say, oh, those patients, they don't understand, and then we blame the school system, and then we blame all kinds of things. And yet, I believe that we don't do enough looking inward. I'm always fascinated by the fact that in this country and throughout the world, we somehow can get people to drink a fizzy brown liquid that has absolutely no nutritional value whatsoever. And we can get people to drink this stuff by the gallons. And yet we can't figure out how to help people get a better understanding of how their bodies work and what they need to do to remain healthy. And I believe that part of the problem is our motivation, not the patients, but our motivation to make sure that we are doing this work and doing this work effectively. So what I believe needs to happen is that we need to engage in the Ask Me 3 process. So we need to ask ourselves the 3 questions. So what is my main problem? My main problem is that a significant number of the patients that I serve don't understand much of what I tell them about how to get or remain healthy. what do I need to do? I need to work harder to make sure my patients understand the answers to the Ask Me 3 questions. I may need the help of technology and pictures, and obviously I need to make sure that it's language appropriate and grade level appropriate. And then why is it important for me to do this? Well, it's important because I want to improve the health outcomes of the people that I serve. I mean, I've always been fascinated by why is it that we don't employ more on-the-spot technology, in the sense that, these days, whenever I have a significant issue that I am trying to figure out, and particularly for me personally, it's less about health literacy and more about house literacy. So anytime I need to fix something in my house, I go to YouTube. And there's this incredible video there that kind of shows me what I need to do, and it walks me through it step by step. We don't employ that same kind of technology in the course of our work with the patients that we serve. We don't recognize that for some people, they're very visual. They need to see a cartoon in action that is relaying what's going on. Other people need to hear it. And we have, I believe, a lot of the technology already in existence, and many of the messages already in existence that we need. But we are also not incentivized as a system to put this into play. And the first thing those of you who are clinicians are going to say, oh, by the way, I don't have time to do this, right? And I completely understand that reality, but maybe that's a need for us to reframe what we're doing and how we think about what we're doing, in large part because what we're doing right now doesn't work very well. And that's the bottom line. I mean, the health outcomes in this country, certainly pre-COVID, were nowhere near where they needed to be. And certainly in the midst of this pandemic, they're definitely not where they need to be. And so then we're left with this other reality, which is, so we have health literacy as an issue in and of itself, but we're now confronted with an environment where there's tremendous mistrust in the healthcare system, and there's just a phenomenal amount of misinformation that's out there around a variety of things. So the level of mistrust has to do with sort of craziness that I was able to find on the internet about the fact that COVID actually came into existence because Bill Gates invented it because he wants to reduce the population of the world, or that 5G technology is responsible for this virus. And so this isn't just misinformation. This is people fundamentally believing that there are evil forces at work, working against their own health and well-being. Now, some of that is pretty out there and nutsy. On the other hand, we actually, particularly in communities of color, for African American, Latinx, and indigenous folks, we have a long history actually of providing less than optimal health care, very well documented. And we also have a long legacy of resource misconduct. And so these notions of people sort of not necessarily having warm, fuzzy feelings about us in the healthcare system don't just generate de novo. I think some of them are quite rooted in fact. And then there's just, with the advent of social media and the internet, there's just a preponderance of ability for people to put out a lot of misinformation. And so as we strive to work with the patients that we seek to serve, part of what we have to do is not only say, what is it you currently understand about certain things, but to really dig a little deeper on why do you believe this is happening and what are your beliefs about this? Because very often that's when we will get to many of the underpinnings of why these things, of why our patients actually are not necessarily doing what we would hope for them to do. So it is being mindful now on our parts of the kind of misinformation that's in the ether that will help us to do a better job as we strive to work with our patients. So on that note, I will stop sharing and introduce my newfound colleague, Dr. Steven Chen.
Thank you so much. It's always bad to go last when you have phenomenal speakers. However, this time I think I have some answers for some of the things that have been brought up. Chancellor Perman, you said so nicely the issue that's out there. Once a patient leaves your office, your clinic, your hospital, it's a wild, wild west, right? You did the best you could in clinic. You hope that things work out, and sometimes they don't. And so here are a couple of word pictures to illustrate what I'm here to talk about, which is health literacy and medication management. The pharmacy is a place where it's the last chance, right, to get things right before patients go off into their homes, et cetera. The top picture is an example of a patient who saw many specialists and primary care physician here in Los Angeles, and it just wasn't getting to goal despite insisting that she was taking all her medications correctly. Got a pharmacist assigned, and what you're seeing here is 100 bottles of medication, half unopened. Again, despite the patient insisting that she was taking all her medications correctly. The root of it was health literacy, concerns about disease state, medications, and so on, that she just didn't understand fully enough. So this is sort of where we started with her. The picture on the bottom, give you a quick background on that one. I had a patient referred to me who had diabetes, was getting insulin, and was getting that insulin dose steadily increased over time. We know insulin lowers blood sugar unless you're extremely resistant, which no indication was this patient would be. And yet, despite the significant increases in doses, nothing got it better. SMBGs, A1C, nothing improved. So I got to see the patient in clinic, reviewed everything from, did he understand his diabetes? Did he understand the medications? And he seemed to get it. I was impressed. So I said, can I do a home visit just to figure out what's going on and maybe ask a few more questions? Sure, of course. So I drove out to Watts and found his address, only I didn't see any house there. So I went to the gas station next door and I said, where's his address? And he goes, who are you looking for? And I gave him the patient's name. He's right over here. Takes me over to this lot, pulls open a board, and there's my patient living in an empty camper shell in the middle of this vacant lot. So I went, I did my usual home visit. And I was near the end, I said, we give you some extra insulin. Can you tell me where you store it? He said, yeah, in the refrigerator. He points out to the middle of the lot, and in the middle of summer, 100-degree heat, there's his insulin cooking away, basically becoming ineffective. So like I said, when things are handed off, you never know what happens. And that's sort of my message today. I would be remiss to not acknowledge Heather Congdon, my friend Magali DeBittner, and Raymond Love, Nicole Brandt, and of course your esteemed Dean Natalie Eddington over at Maryland, who I think are fantastic experts in this field. I think the only thing I'm bringing that you might not have in Maryland is the incredible diversity here in Los Angeles. We recently polled our students and we found that they speak over 30 languages between them, which is probably about right with the mix of patients we serve. Now, before I get too far and explain the context of my remarks, I wanted to just recap the standard of care for managing medications for patients today in pharmacy. It's called comprehensive medication management, which Chancellor Perman mentioned. It's about getting the right medication chosen, given the wide array of choices that you have out there, making sure the dose is correct, not so low it's ineffective, not so high it causes adverse effects, making sure your drug-drug interactions are monitored, avoided whenever possible, making sure patients can use their devices. Some of the things that you and I think are pretty simple are not simple at all for many patients. And I guarantee you that when you show a patient how to use an inhaler and have them bring it back in a few weeks to a few months, they will miss many of those key steps. And at the end of the day, the medications have to be affordable to your patients. These are all key components of comprehensive medication management, I'll call CMM moving forward. Within that are some other key elements. Pharmacists who provide this service provide it within a collaborative practice agreement that is basically in close collaboration and agreement with physician partners. All medications, all conditions are evaluated to make sure that everything makes sense. And the patients are followed up by the pharmacist until the patients reach treatment goal. So very much a value-based type of medication management. And it's important because it's expensive when we don't get this right. You saw some of my examples of when things don't go right. It's estimated that the amount of money wasted because of suboptimal medication therapy is about 16% of all healthcare costs, over $500 billion with a B. 3/4 of all hospitalizations are accounted for by misuse of medications. And it's actually the third, not the fourth leading death in the United States that's attributed to misuse of medications. So we pay a lot for this problem that we have. One of the, and my personal practice experience has been in Los Angeles, home to 10 million people, more than 43 states in the nation. We have 4 million Medicaid, if you can believe that, almost 3 million uninsured and 66,000 homeless. I started my practice in the VA. I really enjoyed that practice. Moved over to Cedars-Sinai, Beverly Hills, spent some time there, moved back to Skid Row for a good 10 years of my career. And I'm here to tell you today that health literacy is an issue, regardless of whether you're extremely rich in Beverly Hills or in Skid Row. In fact, I will argue that I had patients that were easier to work with and teach in Skid Row than I did in Beverly Hills. Sometimes the folks in Beverly Hills thought they had all the answers and it didn't matter what I said. But the point being that we are talking about certainly the underserved populations, but health literacy and medication regimens that can cause harm are actually quite its own pandemic. These are where I've practiced personally. I will say that I've been able to establish practices all over the county, both in underserved populations and for commercially insured populations. And it's been fantastic. I've really enjoyed it. Even worked at UCLA. We were rivals in athletics, not in collaboration. But one of the limitations I saw is that we struggled with patients getting access, right? We talked about this a little bit before. Where just getting patients to come back to see the clinician was a problem, especially for the underserved. Now, you may say, well, there are clinics everywhere. That's not the issue. Well, no, it's a tremendous issue for a patient with limited means to be able to get back to a clinic on a regular basis. So we try to think about how can we bring these kinds of services, CMM, to patients where they're at. One thing that we did initially is we had a chance to work with the late Dr. Ronald Victor, who pioneered the Black barbershop model of sending pharmacists into barbershops, and showed that by doing so, 90% of patients got to blood pressure goal versus 32% usual care, which was remarkable. We were able to help start that project with him, learn a lot from his amazing work. And we said, look, if we want to make an impact here, it's not going to be one clinic at a time. It's going to be through payers, and it's going to be through the network that's already available. So what we decided to do, let's leverage this network that is highly underutilized in the healthcare system, which are community-based pharmacies. There are over 67,000 pharmacies in the US. 90% of the population lives within 5 miles. Compare that to hospitals, emergency rooms, community health centers. There are a lot of pharmacies out there. And if you want a better context for what that means, there are over 4 times more pharmacies than there are Starbucks in the nation. So that's some pretty serious access. I hope you agree. So what we ended up doing is partnering with big payers that cover over 3 million lives in the Southern California area, IHP and LA Care, to form the California Right Meds Collaborative. And this helps to pair together pharmacies, FQHCs, through the health plans, paying a value-based payment for pharmacists intercepting high-risk, persistently uncontrolled chronic disease patients and receiving comprehensive medication management. We do the training, we do the quality improvement, and we help to design the value-based payment model. So all of that for context, I'm going to translate now into what are some things that your learners might be interested in what's happening here at USC. One of them is that work I was mentioning to you down in Skid Row. The gentleman you're seeing in the middle of this picture is Dr. Paul Gregerson, a national leader in homeless healthcare, brilliant man, heart of gold. He leads the student-run clinic for the University of Southern California, which includes all of the health science disciplines. Basically, a couple times a month on a Saturday, the students all come together and they see a panel of patients for which each of the disciplines has some time to spend with that patient, has a very specific role. And after their evaluations, they come together with him as the preceptor and come up with their assessment and plan. It's a great way to work with a very challenging population and get the insights and experience of Dr. Paul Gregerson in the conversation and learn what each other is doing. So we found this to be remarkably fantastic for students. And one thing you should know is the students set this up on their own. It wasn't a faculty member that walked them through every step of the way. It was students from different schools getting together and say, let's do something so that we can make a difference while we're students and learn what each other is doing in the process. So it's been really fantastic. If you go to this website, you'll learn much more about that program. And then a few other things that might be of interest to you. We recently became the interprofessional education pharmacy partner for the Kaiser Permanente School of Medicine, which opened this last fall. And we were able to connect them with several of the FQHCs that we currently work with in our area as a part of our collaborative, as well as other clinics where we had grants. We're able to establish the value of pharmacists, and they have since paid for clinical pharmacists to work in their clinics. And something that I think was mentioned previously, we do a pretty lousy job of controlling hypertension in this country, about 50% control, and these FQHCs tend to do a little bit worse than that. So we're in the process of collaborating to have our students from the medical school and from the pharmacy school partner and work with these FQHCs, the ones that are struggling the most with hypertension control, to help them improve those rates. So that's just an example of some of the interprofessional work we're doing. The other, I think I already mentioned before, is within our collaborative, we're pairing federally qualified health centers with pharmacies so that we have better communication, that collaborative practice agreement, and then we're able to bring in other learners, not just pharmacy students, but medical students, other disciplines, to be part of that solution for improving health outcomes for these patients. So I had much more of a granular overview of what we're doing in pharmacy, but hopefully that was helpful. And I'm ready to hand it back, I think, to Chancellor Perman.
Thank you, Dr. Chen. I'm having a bit of difficulty with my video camera, but can you hear me?
Yes.
Good. My face is certainly not important to this discussion.
We do see you, Dr. Perman.
Oh, you do? Okay. Yes. Thank you. I'm going to make an executive decision, even though very hard work has gone into allowing us to break out into 3 rooms. But I'm also mindful of time and very happy that our wonderful panelists have provoked us in so many ways. I don't think you need to break out into rooms. I just anticipate the fact that there are many questions to be asked. I'm going to take the prerogative of asking the first, and I'm going to pick on my colleague, Dr. Rogers. Several of you, Dr. Chen, have mentioned teams. You've mentioned interprofessionalism. Dr. Rogers, you're an authority in this field. So here we are discussing problems. Dr. Schillinger provoked us no end. How do teams advantage us, if at all, in dealing with health literacy and the various challenges that have been put before us? Do teams make a difference?
Absolutely. And if we do it right, teams are actually key to the solution to this problem. Because one of the things we want to do is we provide care in the context of highly effective collaborative teams, is to make sure that we're all on the same page in terms of messaging, and then we can reinforce those messages with our patients. What I would offer, though, Dr. Perman, is that it's critically important as we do this work with teams that we make sure we are broadening that definition of who's on that team. Because the extent to which the people who are answering the phones and registering patients are also giving that same correct information becomes really important. And the last thing I'll say is, one of the difficulties we have in healthcare sometimes, particularly when people are working in teams, is physicians can often take on this position that says, well, that's not my job. I don't need to teach the patient, right? I can just leave that to others. And we know that that is not an example of high quality healthcare. We know that everyone on the team needs to be involved, and in ideal situations, the team comes together proactively to talk about what language are we going to use consistently when we talk about certain diseases, right? So when we talk about diabetes, are we going to talk about glucose or blood sugar, or, that's the homework that we need to do as teams in order to do this work effectively. So thank you for allowing me to make and reinforce that point.
Thank you for responding. Dr. Chen, do you want to comment?
Yeah.
You talk about effective use of teams.
Absolutely. Dr. Rogers said something in her presentation. One of her conclusions is that physicians need to work harder to make sure patients understand their diseases or meds, et cetera. I think that it could be partially true. At the same time, I hope you all agree that physicians work awfully hard, and they don't have a whole lot of time in a day, I think, to deal with challenging patients. I mean, in the practices I've been in, typically 10 minutes, maybe at best. You get one patient with that 100 bottles of medications that I showed you, and your 10 minutes is done, right? So I think it's essential that we have teams, participants, team members that, to your point, Dr. Rogers, are fully aligned with what your goal is as a physician, right? That's first and foremost most important. And maybe a great example of how this works is, it actually works the same way every time. When we introduce a physician or a practice to teaming with a pharmacist, pretty foreign to many of them, right? The stereotype image of a pharmacy is still the chain drugstore pharmacist, frankly. And so when we talk about CMM, there's a little bit of skepticism. And then once they start to experience the system of care that we introduced with CMM, they understand it. And I actually have a great recording of a physician we worked with who gave a testimony. And he says, once I realized that someone on the healthcare team that can manage medications just as good and maybe even better than most physicians, then why wouldn't I hand that off and let them help to reinforce the message that I'm trying to make? Well, because I'm so busy trying to diagnose patients, get patients access to me. At the end of the day, it improves care as a whole. So I think everybody wins when you have team-based care that's aligned and you have the right people doing the right jobs.
Thank you. Dr. Schillinger, do you want to weigh in? If not, I'll open the floor.
Yeah, no, I would definitely want to weigh in just to augment what my colleagues have said, to include two issues. One is obviously lay health educators or promotoras is being really critical, and it's getting them funded to do the work. We're well beyond the need for that. I mean, it's been demonstrated again and again, and we need to get public payers and private payers to acknowledge the importance and value of such individuals who come from the community from which our patients also come. And also to say that, unfortunately, medicine has not been as diversified as, for example, schools of pharmacy are. And expanding the team in this way can also yield fruit with respect to the cultural and linguistic backgrounds that the healthcare providers on the team come from, to better align and match with those cultures and ethnicities and backgrounds that our patients come from. And we know from communication studies that ethnic and social concordance is a very important determinant of participatory decision-making. So, and that's just a fancy way of saying it may be that when I'm ethnically or culturally discordant with that patient, she doesn't tell me that she hasn't been taking her 100 pills in the pill bottles or whatever it was you showed, Steve. Whereas if I come from the same neighborhood or speak the same language or sound like her or look like her, she may have more readily acknowledged to me that she doesn't buy into it, or she doesn't understand it, or she hates swallowing pills, or whatever the issue was.
You're all speaking such truths, but I'm supposed to keep my mouth shut, and I will. I applaud the wisdoms that you're offering here. I'm going to turn this over to Alex Lakowski in order to call on people handle the questions, because there are plenty of them.
All right, we have Dominique Gelman. Dominique, go ahead with your question.
Oh, can you all hear me?
Yes, there you are.
Oh, okay. Thank you so much for being here.
Dominique?
We lost her.
Well, I can read her question.
A little background. I'm one of the student president fellows.
Try again, Dominique. One more time.
Dominique, you might want to turn your video off because you're breaking up.
Oh, I'm so sorry. My internet.
Well,
we'll come back.
Well, do you want to come back, or do you want me to read her question?
Not super great.
Read her question.
My question.
Dominique, I'm going to do it for you. I'm sorry. She says, how do we get more professionals to care? You are all incredible examples of providers who know and practice these important principles, but many providers do not. How do we promote buy-in on a larger scale?
Who wants to respond? Panel?
I can take a stab at it. I do believe that providers do care. So if it seems that providers are not caring, it probably is a manifestation of other systematic problems. Obviously, there are outliers and individuals who are not in the business for the right reasons, but I think they're relatively few. But I think there are significant portions of, certainly in the medical workforce, of physicians who don't care because the care has been squeezed out of them, and that they are operating under some form of traumatic toxicity related to all kinds of systemic mistreatments that they've experienced in the course of their training, or that they experience as feeling like gerbils in a rotating wheel. And so the issue of clinician well-being must be attended to, because you really can't care for others in a truly deep way if you're feeling like you're not being cared for. So I think there is a self-care problem we have among the physician workforce, and a problem of how well our ecosystems support relationship-centered care. And so physicians often feel like they are rowing upstream with no paddle. And so a coping mechanism may be, okay, if they don't care about it, if the world doesn't care about it, how can I? And so I think at the most basic level, we do care. And it's a question of sort of how to uncork that, that from toxicity to caring. I don't know, Denise or Steve, if you have thoughts on that.
Yeah, I mean, Dean, I completely agree with you. I think most healthcare professionals of all types care. I'm going to take one of your provocative pills and say, though, that one of the major things that we need to do in order to make this better is change our payment system. As long as we're in this sort of fee-for-service, I get paid for how many widgets I put through. As long as we have people who remain uninsured, we can't do the kinds of things that we need to do in this country to deliver higher quality healthcare and get better outcomes. In Canada, for example, pharmacists have special pharmacy clinics where if you have a patient who you're having a lot of trouble sort of managing their meds, you can refer them to the pharmacist. The pharmacist then takes a look at what they're on, adjusts their meds as appropriate, stops meds as appropriate. We don't do things like that. And the major reason we don't do things like that is because of the payment system. The major reason that we see, a patient every 11 minutes is because of the payment system. And a lot of us are very sort of theoretically afraid of what that would mean for our system, but it's profoundly broken. And so it is yes, taking care of providers' well-being is important, but this is going to require a systemic fix if we really, really are going to do the things that we need to do to, at the end of the day, improve health outcomes and eliminate disparity.
Chen?
Yeah, I'll echo. In fact, I even wrote that word, Denise, widgets. It is a problem. Our incentives are aligned in our healthcare system, are misaligned, in our healthcare system, and that's the root of the problem. Look, in pharmacy, we are in the same boat. We are, in fact, one of the chains, which I won't mention by name, has a color coding system where when you bring in a prescription, the clock ticks and the screen color changes. And at some point, when you hit the wrong screen color, you get a black mark against you. Yet you could be caring for a patient who just got out of the hospital versus a patient that got an antibiotic prescription, and your timing, your clock is the same. So we do have an issue with the widgets causing burnout, causing people to care maybe a little bit less. What we have found is adding pharmacists to the care team in CMM. Physicians are happier. We proved that in our big CMMI grant project, where physicians were quitting every 3 months and they actually stayed in the clinics where we had pharmacists integrated. But pharmacy itself, by the way, pharmacists is not recognized as healthcare providers. I don't know if you knew that under the Social Security Act. So our ability to bill for the services that we can provide very effectively is extremely limited. So that's another problem.
Dr. Chen,
just
thank
add-
you for the dirty little secret about black marks.
Can I just amplify Dr. Rogers' point, which is to say, I think part, if not a significant part, of clinician toxicity is actually related to the screwed up incentive system that you described. But even at a place like Kaiser, a prepaid health plan, where the system has changed, there are widgets and there are quotas, and there is the need to work quickly. What we need to also demonstrate then is the value that providing care in an alternative way. What are the communication techniques? Who are the team members? How can we stop being so ineffective? Which is another thing that contributes to burnout, is the feeling like I've got the same patient with diabetes and I'm having the same conversation with the same bad outcome. It can lead to a lot of negativity. So how can we actually become more effective in our jobs through communication, through teams, through collaboration? I think that can only happen in a prepaid health system.
Dominique, thanks for such a thoughtful question. Alex, where do we go next?
All right, Kavita Bhatnagar has a question that is so critical right now. Kavita, let me get you to turn your mic on. Are you there? Try again. Kavita, are you there?
I saw her question in the chat box, and
you know what it is, right? It's about medical mistrust. And what can we do to overcome that now that our patients have a sense of mistrust from decades of poor treatment from, institutions and individual providers? What can we do to overcome that?
Panel, who wants to start?
Oh, I'm spending a lot of time
talking
Dr.
about Rogers.
This in the context of COVID, so I'll take a stab at it. I mean, I think the first thing we need to do is acknowledge it. Over time. I mean, I think one thing to do is to say, one of the things that I experience with a number of my patients is, folks don't have the same trust in the healthcare system that they used to. And, I don't know how it is for you, but, I really want to work with you over time to develop trust, because I want you to know that I'm going to only tell you the truth the best as I know it. And when I don't know, I'm going to tell you that I don't know. But we're going to be partners in me working with you to help you get the very best health outcomes that you can. Because I think that's an important thing to say, not only about mistrust, but also about race, ethnic, lack of concordance. So Dean, the data that you were saying is very compelling, and we know it, right? We sort of know that difference between a patient who sort of, based on what you look like, makes assumptions that they can trust you differently. Well, sometimes that's true and sometimes it's not true, quite frankly. And I think the key in all of this is the more open communication around it, because quite frankly, there's just not enough Black doctors, for example, to take care of every Black patient. And so acknowledgement around these issues and being willing to just spend a few minutes having these conversations, I think can go a very, very long way. And obviously the key is to not walk in with this attitude, I'm the doctor, I know best, do what I tell you to do, because that's a trust killer right away.
Dr. Chen, any comment?
Yeah, I think at the very you're absolutely correct. At that granular level, you need to give them the time they want and answer the questions they have. I can't tell you how many patients I've had, whether in Beverly Hills or Skid Row, come in saying, I'm just frustrated. I don't know why. First of all, I don't even think I have a medical problem. Secondly, I'm not sure why it's so important to treat it. And what are all these medicines I'm taking? Why do they make any sense? So you let them vent, you let them express their frustration, and then you find the way to reach them in terms of their values, right? How does this match up with what's important to you, that sort of thing? And I know I'm preaching to the choir now. Maybe on a more broad level, have we thought more about how do we bring care to patients in areas where they do have trust and relationships and leverage those? I think the barbershop example by Dr. Ron Victor was brilliant. Take care into what's very much a cocoon, where Black men have a social gathering and try to bring care. And he was nervous, by the way, about doing that. He was afraid it would disrupt that that very important social environment that took place there. But he found that the opposite, that it was welcome and it worked, very effectively. And probably one of the keys that he used to engage patrons in this program was he would get some initial men to sign up and have some success stories. He would then post these stories on the wall with their picture, with their permission, as a testimony to how important this is. And you may be surprised at how effective that was at engaging more patrons. We're trying to do the same thing with pharmacies. Pharmacists are one of the most trusted professions in our nation. And I don't know if you know this, but the average Medicaid patient sits in a pharmacy 2 to 3 times a month and trust their pharmacist for advice. So, we're trying to leverage those places, those professions to overcome that mistrust issue.
Thank you. Dr. Schillinger, building trust, comments? No? All right.
I got a lot to say about it, but let's go to more questions.
Okay. Alex.
All right. Deborah Boers, I think, just dropped out. I'm having bad luck with people here. They're dropping out on me.
I'm here.
You're there? Oh, go ahead, Deborah.
Yeah. My question was, could we try to create a position of health educator at every doctor's office, so at least one person in every office would be an expert in health literacy and would have the time to spend with patients?
I can hear the echoes of who's going to pay for it. Please.
If we have a prepaid model, and we can show the value that such an individual would generate with respect to quality and outcomes, it's a no-brainer, right? And I would say places like Kaiser and places like the United Kingdom have exactly these people. There are certificates and training programs to enable such individuals to be trained and receive careers in this field. And so I think it's a great possibility in the right fiscal context.
Other panelists comment?
I'll just quickly add that because we're not providers in the healthcare system, what Dean says is exactly what pharmacists have to do. We have to find ways to show that our work generates value. And by the way, value means an ROI within 6 months in most cases. We can't achieve that, then most payers won't pay for it.
Thank you. Alex.
All right, let's bring in Ramon Martinez. Ramon.
Hi, can you guys hear me?
Yep, go ahead.
Yes.
Hi, Dr. Perman, nice to see you again. I like the comment that Dr. Schillinger also talked about with cultural competency. I grew up in the Bay Area in the Latino community, and I completely get this idea of, culturally competence in determining how you approach your science, your health. My question is, how can we as a university system engage in with the state government to make a more proactive role in making health literacy and science communication culturally appropriate? Things like public education initiatives, or perhaps university system funded health advisors that can work with politicians at the state house or even at the federal level.
Panelists? I think you're giving the chancellor an assignment here, so I'd like to hear what the panelists think.
Well, I actually was going to pass it to Dr. Bauer because none of us are working in the Maryland context to know what the levers are with respect to Medicaid state policy and Department of Public Health policy and what would be needed to elevate the issue of health literacy across health and, quite frankly, social service departments as well.
Dr. Bauer, you're in the panel.
Sure. So just quickly, I will point out that this was an important enough issue that we devoted a half a day to health literacy and health policy in Maryland at our 2019 Health Literacy in Action Conference. And we looked at the Maryland Primary Care Program, which is a statewide initiative based on a waiver that the state has with the Centers for Medicare and Medicaid Services to do value-based care for Medicare patients. And we've had a lot of conversations about how health literacy could be integrated in that model. We actually have 2 state laws, which were the impetus for this whole program for the Empower proposal, because Maryland has 2 laws on the books that say our students, as well as our practicing providers, should be trained in health literacy, health disparities, and cultural competence, but they're just recommended. There are no requirements, there's no licensing requirements. These are just like nice to do things. And so I was very interested, given that we had those laws and people had worked hard to get them passed, what should we be doing as a university system to bring those into reality, given that, you know, what we've heard here today and what you'll hear from the students on April 6th. So I agree with you. I think policy has a role in this, and I would love to see the University System of Maryland really be a champion for health literacy, health education, both at the K through 12 level, at our professional levels, because I think the opportunity is really there. We have some of those policy levers in place here in Maryland. We're very unique in that way.
I'm going to pick on Dr. Rogers because she's the accreditation expert. Should we get made to do this, Denise?
Yeah. I mean, I think at some level we should get made to do this because, quite frankly, there are a subset of people who will learn something because they will opt out of doing these things when they're just optional. But what we need to get made to do more than that, Dr. Perman, is to take the next steps. So health literacy is critically important. I wouldn't be here today if I didn't have passion for the need to improve health literacy. But then you got to do and partner with community-based organizations to take those next steps. So when Dr. Schillinger tells his patient that she needs to eat a DASH diet, we have to be willing to lend our voices to those community-based organizations that are trying to get a grocery store in the neighborhood. We have to lend our voices to those who are trying to end homelessness. And I'm not saying, please don't hear me saying that we as health professionals have to solve every single problem of the world. But what you are hearing me say is that we as health professionals need to be more willing to speak up when we go to our state capitals to talk about things like health literacy requirements, to say, oh, by the way, I do want to remind you that that's not enough. That our overall goal in promoting health literacy is actually to improve health outcomes, and we will not improve health outcomes until we do a better job of ensuring that there's no homelessness, that we really work to eliminate poverty and that sort of thing. And that's where I believe we become limited in our view. We get very narrowly focused as opposed to being willing to talk about what really needs to happen in this country. And personally, I believe COVID has been such a bright light showing how horrible these disparities are for millions and millions and millions of people, that we have a different ability to engage in the conversation. So yes, let's require people to learn about disparity and require them to learn about health literacy, but let's also make sure that as a university, you and the staff who work with you are aware of those community-based organizations who are engaged in working with these other problems and lend our voices in support of them where appropriate.
Denise, let me bring that actually back into the health literacy tent. That is public health literacy. So public health literacy is about our ability to communicate to stakeholders to increase their public health literacy so that they understand how these social and environmental structures can contribute to good health or poor health. It's so that we can become more literate about what are those NGOs and community-based organizations. Actually, is there somebody working on grocery stores that I should be talking to? How can we make those partnerships part of our solution? And that is part of the public health literacy dialogue.
Good. We have time for one more question. I'll leave it to Alex.
Oh, you do? Well, let's bring in Henry Inigbenison, if I can find you there, Henry. I skipped his question earlier, and we just realized that. Go ahead, sir. Henry, are you there?
Yes, good evening. My name is Henry. I'm a student at the University of Maryland School of Nursing and privileged to be one of the President's Fellows this academic year. My question relates to basically in a situation where a patient with limited health literacy is identified. We've discussed some of the resources and interventions we're supposed to implement. However, once that's done, we know some patients' visits are limited towards the amount of time they have allotted for that visit. So for instance, a follow-up visit is limited to 30 minutes. Initial visits limited to 45 minutes. By the time they get triaged, by the time, you do all these things in your assessment, you only have about 10 to 15 minutes to discuss with the patient. So let's say you've identified they have limited health literacy. What interventions can we implement or, to overcome this barrier?
Panel, we have time for one response. Who wants to take it? Dr. Rogers.
No. This is Dean Schillinger's world.
Okay,
Dr. Schillinger, you have
I want to make sure that the barrier that we were referring to is the need to take more time than we are allotted. I think what you're suggesting, and that even if we're using best practices, we need more time. And I think that's absolutely right. And it is why we need exactly what Denise talked about. We need to leverage technology much, much more effectively than we are. The inter-visit period of time is where people live, right? That's where we should be situated more. The lay health educator, who is a relatively low-cost, community-based intervention who can help support people who are falling through the cracks in the middle, are absolutely essential. I also believe firmly, and this has been borne out in research, that if we actually use these communication practices, that the need for more time becomes dramatically reduced. We become much more effective and efficient. We showed, for example, that use of the teach-back method actually was associated with visits that were shorter than visits that did not use the teach-back method. How's that possible? I think we have to move beyond the reliance on the physician, I think has been said many times, and we need to leverage technology and families and caregivers. But it's a challenge, and I don't think we're under any illusion that we will ever hit the utopian 100% success rate. I also just want to call out Alice Horowitz. Hello, Alice. You're why we're here today. Congratulations.
Well, I know how to finish up a program, so I'm going to share with you, given the fact that I happen to mention my Tuesday afternoon activities. Some of you know I'm a pediatric gastroenterologist. And to illustrate Dr. Rogers' point, Dr. Schillinger's point about the use of technology, I want you all to appreciate that when I and my colleagues, I see Dr. Steins here, have a patient with chronic constipation, we have a wonderful video. Denise, it's just like you were talking about, cartoonish, etc. You know what it's called, ladies and gentlemen? The poo in you. And on that note, I'm going to turn it back to Dr. Jarrell.
How can I beat that one, huh?
Are you saying we've been BSing?
Oh my goodness, Dr. Jarrell, I'm done.
Let me make a couple of closing remarks. First of all, I think getting to what Dr. Rogers said about changing the reimbursement system, of course, we've all seen in COVID the sudden emergence of telehealth. Telehealth was totally unsuccessful in most of these places because nobody reimbursed for it. Now, all of a sudden, the majority of our visits are done through this new mechanism. Whether it's better health or not, well, actually, I think it probably is very good health. So we know we can change. But I want to get back to the purpose of these white paper conferences. The original idea was for a group of students, and I do say students because they're the most creative and forward thinking here. The purpose was to identify a problem or issue that was really important to our university and local community, and then to come up with, or illuminate, if you will, potential options or changes or programs that the university could consider, figure out how we might do this, and then actually institute them. And for our panelists, I'm happy to tell you that the record for this that we've had has been quite good. For example, one of the groups recommended a community engagement center. We have one now 4 blocks away, a major part of the UMB effort. It was to talk about interprofessional education. We now have a major program in interprofessional education. They recommended that we have an innovation center, and we established a center where students and community members could come up with innovative ideas and get help and advice. And of course, more recently, to have a cultural sensitivity or a cultural center on this campus that would allow students and others to have a place to go to talk about issues important to them. And in fact, just last year, we instituted this exact program. So what has been said today is very inspiring. But what I hope will happen is that our students are listening. I hope that our students will think long and hard about what does make sense, what we can accomplish in the very near future. And then I hope you will see change on this campus, somehow related to the topics that we've been talking about. I don't want to preempt the students. I want to wait and hear what they have to say. So with that, I want to thank you all. Chancellor Perman, thank you for being here. Dr. Schillinger, Dr. Chen, Dr. Rogers, a great discussion. Nice to see Dr. Rogers again, and I hope to see you again. And certainly to thank Dr. Bauer and also Dr. Steins for driving this whole program to, I'm hoping, a very interesting conclusion. Our final symposium will be on April the 6th at 4 p.m. The fellows will present their findings. So with that, I want to thank you all for being here. Have a good evening. Good night.
Thank you.